Thank you and welcome everybody today to our webinar. We are so pleased to have you here today. I'm going to let Jeannie Luciano from the American Heart Association kick us off while I get my slides up.
Thanks, Emily. Hello, my name is Jeannie Luciano. I am the Senior Manager for Stroke for the American Heart Association. You want to pull up the slides, please, Emily?
Yes.
We're going to go over some housekeeping before we get started with our wonderful webinar today. Okay, perfect. Next slide, please. So just a quick disclaimer slide. So the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the American Heart Association or the American Stroke Association. The American Heart Association, American Stroke Association does not endorse any product or device. So before we get started, we want to run through some housekeeping. So recording is in progress with all attendees in listen-only mode. The slide deck will be available after the presentation. Will be sent out with a recording after the webinar. A link to the recording will be emailed following today's presentation. If you are experiencing any technical difficulties, try refreshing your browser, logging out and back in. If these steps don't correct the problem, please contact your Zoom customer service team. You can enter your questions at any point in time during the question and answer session that will follow both presentations. But at any time, you can enter them in the question and answer box. Closed captions are available by clicking the icon at the bottom of your screen. So we are really kicking off 2026 with a wonderful and informative talk by two really esteemed speakers. So our featured speakers today are Dr. Teresa Savilis and Chastity Orr. Next slide, please. So Dr. Savilis is a vascular neurologist and the director of the Academic Advancement of Telespecialists LLC, where she has developed continuing and graduate medical education programs and Telestroke research program. She is an adjunct assistant professor at the University of North Carolina, Chapel Hill, working with medical students on telestroke shadowing and research projects. Dr. Savilis is a chairwoman of the Telespecialist Telestroke Registry, which is one of the largest telestroke registries in the world. Our second speaker will be Chastity Orr. Chastity, as you can see, has gained this esteemed CPAHA, which we will talk about later in our presentation. So Chastity Orr is the Director of Crisis Services for Lutheran Family Services, with over 21 years in healthcare and 17 years as a registered nurse. She has led stroke and telemedicine programs and helped Great Plains Health achieve the AHA highest Get with the Guidelines stroke recognition. She is a 2017 March of Dimes Nurse of the Year for clinical excellence. Chastity is passionate about advancing stroke care through telehealth, data-driven improvement, and education. So, Dr. Savilis, the floor is yours.
Hey. Hi, everyone, and thank you for that lovely introduction, Jeannie. And I'd like to thank the American Heart Association for inviting me to speak today. Telestroke has been my passion ever since residency. I always knew that this was really what I wanted to focus my career on, and I absolutely love seeing how it has broadened over the last decade and become really highly utilized. So I'm excited to talk with you about it today. Kind of the little quick overview of what we're going to run through, talk about Telestroke and kind of what it is a little bit. I know most of you probably know that already, but a little more detail. Some requirements for successful program initiation and how we maintain high quality stroke programs, as well as some success stories. So as we're talking about Telestroke here, just so we're all on the same page, there are some varying definitions out there, but in this setting, we mean audio and visual real-time communication. So using carts, not phone calls, and really making those acute stroke decisions in real time with patients in the ERs or inpatient throughout the country. We've seen that telestroke really does increase thrombolysis rates throughout rural areas in particular, reduce door-to-needle times, reduce hospital stay, and lower 30-day mortality rates for rural areas. So we've seen a lot of very positive findings for telestroke. And it's also really, well, initially was a very US based in some ways, and and our other colleagues in Canada or Australia and some other places. But now it really is global. We really have been able to have the ability to spread it to far more rural and locations that are really in need of these services. And despite this huge growth of telestroke, there's still kind of limited data that's very limited guidance that's very specific to telestroke. There are two publications. The American Telemedicine Association has telestroke guidelines, and the Canadian Stroke Best Practice Recommendations also have those guidelines from 2017. So those are some resources, although I do feel that there is still some more need, and hopefully in maybe our next acute stroke guidelines from AHA, we'll find a little bit more on telestroke, but that's to be seen. So when I think of telestroke models, there used to be a lot of different types of models. I think, and at least in our country, a lot of what we're doing is the traditional spoken hub that people think of, where you have the main tertiary care center, and those physicians are doing the telestroke consults to the smaller hubs around them. Some of those hubs may have their own neurologist on the ground, may not be getting telestroke. It all kind of varies, and they all come together to get their higher level of care in the one main center. Where there's also the virtual hub model. Now, this is the model that I'm currently working in, have worked in the previous one before, but currently I'm in the virtual hub model, where you have your private practice group of neurologists who really branches out to all different types of centers, from acute stroke ready, or maybe even no certification levels, through your comprehensive centers, and helps to be that bridge with all of their own individual ways of getting from a spoke to a hub, or maybe it's already a hub center that can do thrombectomy or that higher level care. But it's kind of the two main models that I think of telestroke. And if you're here already, you probably already have your why, but there's a lot of whys that people pick telestroke as a way of delivering care in their hospital. Sometimes it's a rural location. Other times it's that the hospital is just too small to really have a staff neurologist be there all the time. Or they have a local staff neurologist, but they can't get 24/7 coverage because one person can't live their life on call. At other times, it's not a lack of that, but it's really wanting to maintain their patients, and in those rural locations, reduce their transfers, or reduce the burnout of their staff neurologists they have there. Say you have two neurologists, but even every other weekend overnights gets to be too much. So sometimes telestroke can bring that quicker. And the other situation we often see is kind of overburdening of the hub. If you have telestroke at some of the spokes that would just always send to the hub for every stroke patient, they may be able to stay there closer to home and reduce that burden on the main tertiary care center. And also improving response times. Sometimes, depending on your campus, like a comprehensive center can have a really large stroke campus, clinics over here, and getting to the ED and doing all the different jobs, we actually can pop on the screen far quicker and get to that patient and save 10, 15 minutes, even if you are within that own hospital system there. And that has direct implications on our times and our quality of stroke care. So now we're going to talk a little bit about requirements for program initiation and how you can successfully start things off. So the thing that I always think about is getting everybody involved that's going to be a player in this program. It's not just the neurologist that's needed. You need your EMS to know so that they can pre-notify. You need your front desk triage person to be prepared to call in that stroke alert for tele-neuroconsult in that way. You need your ED nurses to know how to use the equipment. They need to be educated on the process, know the steps, know what goes where and when. your ED providers, your CT techs to understand sometimes the cart's going to come in between a CT and the CTA. There's so many different ways that all these people play a role in the process, and everybody knowing their role and the parallel roles that are going along with them really helps it to flow smoothly in the ED. And then when you get up to the stroke unit, the ICU nurses, internal medicine, that's all the inpatient care for the inpatient stroke alerts. They need to know how that end of it works. And obviously, one of your most important people here, your stroke coordinator, who's kind of helping devise all these different workflows and keeping it, educating everybody on their role and helping to readdress all those processes. As well as if you have a local neurologist and then the teleneurologist role in it. So identifying which key players you have in your facility and getting them involved early is super important to a successful initiation. Before you can start a program, you need to think about who's going to be covering it, whether it's going to be, some of these forms just to throw out there are stuff that we use standardly. So you will see the telespecialist thrown in there. It's much easier to kind of use some demonstration pieces, not that you can't just substitute any telestroke services that you're using or your internal, but thinking about who's going to be running it. Is it going to be a model in which you have the third parties like we do doing 24/7 coverage? Is there going to be a time when you have somebody outside, the neurologist outside, and a mix with your neurologist? How's that coverage model going to work? First and foremost, you need to figure that aspect out. Then it's really figuring out how all of those people are going to have access to the information they need. So they need EMR access, they need PACS, they need to be able to get to the CT techs, we need to have the CT techs there and available 24/7, and the ability to have radiologists giving timely reads on those scans and on the CTAs, and making sure that's all set up and available with your resources ready. And then figuring out how you're going to do your notification process. For us, we use an e-alert notification system through our RRC, which is kind of our call center that we use. But how is that stroke alert going to get out? How are you going to get the neurologist, the teleneurologist on board with your team? That's an important piece to figure out very early. Then thinking through your workflow. How you're going to get a wait early, where you're going to get them, what triage tool you're using, be fast, what the workflow is going to be with when they get assessed and when they go to CT, and really thinking about just kind of all of these pieces that would come together to make a stroke alert run smoothly. And it may be different than it is if you're transitioning from in-person. You are doing mostly the same things, but the order might need to change, and who's assigned which role might need to be different in order to make this work. And then kind of the last really key piece here is your internet. You need really good wireless internet in your facility to make sure that the connections stay, and getting the right cart, teleconferencing software, and making sure that's all set up for you. This is just an example of all of the moving pieces that go into getting ready to go live with telestroke services. It's not something that's as simple as, I'm going to do this tomorrow. You really want to think out, plan all those different aspects we were just talking about, making sure you have the physician coverage, looking at how your process should work and what fits your hospital to make that work, practicing, educating before you really go live with patient care in that model. And the kind of EMS and different ways of envisioning some of that workflow. This is from a paper that I wrote looking at arrival to notification time. So we were looking at thrombectomy workflow, but I feel like it gives you a really great example of how process changes based on what you have. So if you have EMS that pre-notify you, doing that extra step of notifying the teleneurologist when you get notified by EMS, getting them on screen and having them basically at bedside the second the patient arrives, and being able to go through that transition process with you can really improve their treatment times, not just for intervention, but also for thrombolytics. And that changes when it's a triage or EMS didn't recognize it. You're kind of lose that little bit of time, on-screen initial time, and there is some reiterating that needs to be done because the neurologist really wouldn't be there on screen until later in that process. So just ways to think about those different workflows. And so once you kind of have your program initiated here, then we talk more about how you maintain it. So as I already mentioned, step one, defining all those key players on your team, going through your current process and how a stroke works, whether it is an in-person neurologist, if it's ED, if you're a small center that really never had a true process before and is trying to become acute stroke ready and developing this, then there may be a lot of changes in there, but figuring out what you have and what you need to have and what seems to fit best with your workflow. Once you've identified that plan, now you need to think about how do we get that to happen? How, is there more resources that we need? Is there education that needs to happen? How do we get ourselves to that place that we want to be? And then you go about, education, getting all those things into place, and then you're ready to kind of go live and start following this through. And that's really where the quality part and implementation go together. Because once you figure out what you need to maintain it. And what you thought you needed may change over time as you actually start playing out these stroke alerts in real time. So the rapid eye process is what we use to kind of look through this here, which stands for Real-Time Acute Stroke Process Improvement Driven Initiative. So in our situation, we have a software called Telecare that is able to capture all of the stroke metrics, very similar to what a stroke coordinator captures anyway, probably a few extra times and things that we look at specifically for Telestroke. But then it automatically triggers us when there's outliers from our goals. And we will go through those goals in a minute. And that way you can kind of be in this constant cycle of process improvement and really getting to figure out what causes the delays that you're having and how you can meet goals for that. So, and again, bringing in that ongoing education and including all your team members. So some of the benchmarks that are particularly important to Telestroke that you may not really see in your regular in-person stroke alert is, our first time interval is symptom onset or the arrival in hospital to the activation. And activation here means activating your teleneurology services. And our goals for that, you'll see some mention of internal metrics for us here. There is no standard metrics for these things, but we have our own internal that we try to follow. So for EMS, the goal is for them to pre-notify, which would be 0 minutes. And if it is a triage patient or one that wasn't identified by EMS, the goal would be less than 10 minutes. Then the second piece of the process is the activation to assessment start time. So when they call to getting a neurologist in front of the patient. Now that's not necessarily a neurologist on screen, it's actually with the patient, which is why this time is a little longer than our typical response to screen, which is like 3 minutes. The 12 minutes is because sometimes they're on the CT table, sometimes their cart is not where the camera is, the cart is not where the patient is. So it can take a little bit longer to actually start physically assessing them, depending on that whole parallel workflow that's happening on the ground there. So that goal is 12 minutes. And the third would be the neurologist assessing the patient to actually making that thrombolytic decision, which is less than 10 minutes. That's a goal, not a goal that fits everybody, because sometimes you do have a more complex patient and you obviously need to think through, and we put patient safety first, but that's kind of the overall goal to be able to make some of those decisions. And then the fourth would be getting that decision being expressed to the nurse on the ground, actually getting the thrombolytic into the patient is a goal of 8 minutes. And so here I'm just going to kind of go through what we have as best practices. As I mentioned earlier, there is kind of limited guidelines and changes for telestroke as compared to in-person stroke alerts. Personally, I think that given the various settings, there are certainly considerations we have to take on what are things that everyone can do, but that there are a lot of similarities and ways to improve. So these are what we use. I'm sure other places have some other things that they would add to it or that work differently for them, but I figured these were a good place to start sharing here. So as I've mentioned a few times already, the EMS pre-activation, letting the neurologist, the teleneurologist know before the patient arrives so they can physically be there, hear the sign out from EMS, and be a part of that whole process through. The early activation in triage, so having them notify us right away while they are also like not waiting for the CT to be done or waiting for other things to happen, just getting that early activation right away. Delayed rooming might sound a little off to some people, but actually taking a patient, putting them in a room, moving them to a bed, not taking them either to CT or having like a pit stop in the hallway, which we'll talk a little more about too real quick, makes a big difference because that rooming time really slows you down. So either having a direct to CT process or the pit stop process is really far more effective in keeping that flow through. Getting the weight early, ideally if you can get it before CT while it's transferring them over. If not, getting it immediately after head CT so that the orders and the mixing can be started as quickly as possible. That quick pit stop that I mentioned is really a place in the hallway where you can get the ED doctor, keep your stroke cart, have a blood pressure cuff, draw your labs, get that IV and do that like quick, less than 5 minute stuff that you need to do to get them onto the CT table so you could treat them right after. It's also a great place that if the cart's right there and the ED doctor comes over, everybody can hear the story at once, can get EMS sign out, and really be very productive. Managing patients with concurrent chest pain. Now, while this is not something that happens a ton, we do worry about aortic dissection, and that's something that requires imaging. So if you can identify these patients early, we have actually found that a CTA chest stroke specific order set is really helpful because one of the big slowdowns can be getting radiology to realize it's a critical study in that way and that it's delaying thrombolytics. So that can be very helpful to get it done quickly. Having a stroke kit, which has your thrombolytic, your blood pressure meds, syringes, tubing, everything you need, whether that's a physical or virtual kit, something that can really help speed things along as well. The early assessment and management of blood pressure. So getting that as soon as you get in, getting it from EMS or right on arrival in triage. Mixing at the bedside for thrombolytic. With T&K, I think we're seeing that a lot more, but not everywhere. Having to get a drug from pharmacy really just takes too long for strokes. So the other things that we have found really critical are incorporating the teleneurologist into that CT process, taking the cart to CT with you. You can examine while you're getting an IV for contrast. You can do things in between. And even better, if you know you're going to treat, being able to push the drug in CT before you do the CTA or at a stop in the process. So that way you're not waiting to go back to a room and delaying that treatment time. Getting rapid labs with less warfarin, a lot more of the DOACs. We see a lot less need for labs, but there's still times that they're needed. So if we can get them sent out at that initial pit stop, that's ideal. Doing frequent mock stroke alerts. This becomes, I think, even more important than it is for the in-person because of all these extra moving pieces of grabbing the cart and the workflow. It's keeping everybody familiar with the process, particularly for places that aren't seeing a high volume of stroke alerts. Critical communication, and that just goes all around. There's physicians talking to, getting family members' numbers so they can talk to them, including the ED in the process. But one of the biggest things is when that teleneurologist gets on the screen, having the team be ready to share all the critical pieces of information for them to get into the chart and know exactly what's been going on up until that point. And then the last one is the utilization of an AI platform for the advanced imaging to help with the rapid identification of LVOs and getting them to their endovascular treatment more quickly. At the end, I do have references for all of these. Not every single one has necessarily a reference, but most of them do have at least a few that we're taking that from. So when we think about the common struggles, the problems that we see at tons of hospitals, with my particular group, I want to say we're probably in like 400 to 450 hospitals right now. So we see a lot of different issues from all the different size facilities. So getting that timely activation of the stroke alert, and there's sometimes disconnect where an internal stroke alert is called, but it doesn't get the call out to us. And that fluidity of that process and making them happen simultaneously is very important. Or there can be the concern that the physician is the only one that can call, and nurses are not given the empowerment to call the stroke alert. That definitely slows things down when you have to have multiple people assessed before you call it out. So having, again, all along those same lines is a consistent process. However it's going to happen, make sure that it's happening that way consistently and everybody knows who can call, who not to call. Don't say nurses can call, but then not have everybody educated and empowered to feel like they can really do that. The other would be dependable technology, making sure that you get the Wi-Fi that's quality in all the rooms, not just some places, not losing the connection, getting the right equipment. Those things can be certainly a struggle, definitely when you're on a budget and you got to work with what you have, but that's ideal, is to get the most dependable thing possible. And then user error. So there's lots of things that can fall into that. It can be not knowing how to restart the cart, not knowing how to turn it on, not knowing how to change the volume. We see all sorts of things where, the cart's handed over to an ED, but the nurses aren't actually educated on how to do some of these things. And all these carts are different and they're not that intuitive. The user error also comes on the other side, making sure that your group of teleneurologists is very educated in the platform that they're using and that they're not making those errors as well. So that goes on both sides of the spectrum. And this one, I think, is huge just for something that people don't think about all the time. How you present this technology, this use of a remote neurologist to the patients is so critical. When the nurse comes in, or ED doctor if they're at bedside, and introduces the teleneurologist as the stroke expert who's here to help you, or knows their name and is able to say things like that and explains this process to the patient, the encounter goes so different than when they push a cart up and walk away. That doesn't make the patient feel like they're in a unified environment where everybody's a team taking care of them. And it really sets the stage for how that patient perceives both the hospital as well as the teleneurologist. So always remembering to keep that united front, and showing that we really are the team that we are, because everybody is working together for the same cause of trying to improve patient care. The simultaneous processes and decision making, that can sometimes be challenging because everybody's trying to do something, and when we don't have hands and somebody needs to be those hands for us, that can make things a little harder too. So making sure all those roles are clearly defined so everybody knows what they're going to do. Another one that might seem kind of silly, but having a consistent location that you keep your cart, knowing that it's there, and having shift checks that the battery's charged, that it's plugged in, that it's going to function, and making that a part of the everyday process of somebody in the hospital to know those things are working. And these can all just make a huge difference in how smooth the stroke alerts go. So now I just want to touch on a few success stories. Like I mentioned, we are in a very large amount of hospitals, so this is just going to touch on a few of the positives. But it's just, I think I'm missing a slide. Okay, so I'm going to do this a little from memory because one slide does seem to have disappeared here. But this is Telestroke supporting a critical access. So this is about a hospital that we, I'm gonna pull up my first slide on my screen for 1 second. So that it's a small hospital in Florida. So if I want to remember, it's I think about 20 beds. It's a quite small hospital called Hendry, and they were looking to improve their door-to-needle times, to use Telestroke to really bring care to this very rural small hospital. And we, through some various process improvements that they did, leading to some education surrounding their, get it pulled up, surrounding their notification process, as well as
Do you want me to stop sharing and you can share over me?
it's just the one slide. I was just going to read it, so we don't have to worry about messing with that, but at least I can say it. Okay. Sorry about that little delay there. So it's Hendry Medical Center, which is 25-bed critical access hospital. Sorry, I knew I was close there. And so they really were they wanted consistent loaded or needle times, and they thought Telestroke was going to be a way to help do that. They knew they had a lot of late stroke recognition and an inconsistent stroke process. So the strategies that they used were they found stroke champions to educate their team members throughout their different departments. They did a lot of training and case-specific feedback, and then they really educated on EMS pre-notification. So they had BFAST being used throughout their EMS systems, and using that process, they got a stroke kit, they got a pit stop. And this is where we can see how much they improved. They had a 54% reduction in their median door to needle times, 50% reduction in their mean activation times, so the time for them calling us cut in half. And they got 11% increase in EMS giving those pre-activations. So over a short time of education, they saw a very large amount of improvement. And when you think about our AHA goal or Get to Good Guidelines goals, they got a 67% increase in their cases less than 30 minutes. And so in addition to all these great patient-specific parameters, they were also able to get their acute stroke ready certification. So Telestroke really did make a big difference for them. And so another hospital here that we're going to talk about, which is really highlighting how you can bring high quality care to rural communities. So Winona Health, which is a 49-bed hospital in Minnesota, it was already acute stroke ready since 2014, and 2023 was when we started working with them. And at that point, they had very limited stroke data. Their guess was that their door to needle times were 60 to 70 minutes. They didn't really have that solidly for us. And they wanted to improve that. They thought getting Telestroke services could help them get these times down and do have better, higher quality care for their patients. So some of the key issues they noticed were also that activation issue. They did have some concerns about their Wi-Fi and their ability to have carts function on there, and inconsistent process with where they were going to notify after all the imaging was done. So the strategies they were looking for was education on early recognition, upgrading their technology so that they could really have more reliable data there, and then really collaborating with everybody who's in the process, like we talked about all those key stakeholders, and then having this parallel workflow. And so they had a 55% decrease in their door to needle times, 30% increase in that door to needle less than 30 minutes, and 19% faster activation. And so one of their big successes they felt was bringing the cart to CT. That was where we really saw the change and keeping the neurologist a part of the process all the way through. And my last example here is not so much in the data numbers, but more thinking on the higher level and what Telestroke can really do for a center. So here, Bay Care's Winter Haven Hospital, this is a large hospital, 447 bed in Winter Haven, Florida. They were a primary stroke center, and they started Telestroke services in 2017. So at that point in time, Winter Haven's not quite as rural now, but it was very rural at that time. You know, with national neurologist shortages, it's very challenging to keep local neurology coverage. I think they had a single neurologist and kind of utilized our services to supplement that, and be able to they were really looking for a way to have that consistent care, because one of their goals was to start offering thrombectomy. So over the next few years there, they were able to get that consistent service with both telestroke and teleneurology rounding to cover the gaps with the local neurologist, and were able to achieve the primary stroke center plus in 2020, and are one of the, I think, 2 centers offering thrombectomy in that county. And so one of the real big successes I feel there, I was heavily involved with Winter Haven over the last 5 years. So very proud of everything they've done on the ground, the nursing team, the communication, everybody has done a really amazing job at trying to build this program into the best it can be, especially with a lot of fluctuations, again, in those local neurologists. And they're willing, sometimes they get, outpatient who are willing to come inpatient, but then they don't want to do it anymore. But having that flexibility of teleneuro to jump in and fill in those gaps, so they always kept the coverage they needed, and they've been 24/7 telestroke for that aspect of it too. But that's really allowed them to continue to maintain such high quality care while they went through that, and even getting up to Gold Plus last year. So I've been very proud of everything that's happened there, and all of the hard work and the way they have partnered so well. And just some examples of those partnerships, as I mentioned, the ED physicians, nursing staff, teleneurologists, the process improvement, the discussions that happen there, the identifying champions in each department, and just collaborating to really make these services the best they can be has been wonderful. They were also very early adopters of T&K and collaborated well, lots of communication, protocol writing, and everything to make that really seamless with just telestroke coverage. And then they were also at the point where they really integrated telemedicine and teleneurology throughout their entire service line, from reading EEGs to the acute stroke to the rounding to all of those aspects of filling in the gaps where they need to be. And they also were able to still have local neurologists come in when they were available, and that was an interesting option. So just to kind of sum things up here, clear, consistent workflows for Stroke Alert are an absolute must for telestroke programs. Education for all the key players and identifying those key players early. Having high quality, reliable technology. Routine cart checks for connectivity. Regular feedback from all the players, and the willingness and ability to modify your process with that feedback are what's really most important to having a successful implementation and ongoing telestroke program. These are some of my references, as well as all those references for our best practices. And I'd like to thank you all for your time. I have my email here too. As you can tell, I'm always willing to talk about telestroke. So if people have questions, you can feel free to email me.
Great, thank you. That was so wonderful, Teresa. And I especially loved the last picture in front of the 100-year thing for AHA. So that was so great. And now we are going to turn it over to Chesty.
Hello, everyone. Thanks for joining us today. I have no disclosures. Emily, you're going to have to move my slides. Thank you. So we're going to just go over understanding stroke care in rural Nebraska, telehealth solutions for stroke management, and improving patient outcomes by using the American Heart Association Telehealth Telestroke certification. So let's first discuss understanding stroke care and challenges in rural Nebraska and rural areas throughout the United States. So when you look at those, one of the biggest barriers is geographical resources. So, response time for EMS, limited specialties. So we're going to talk a little bit about that. The area that we're going to specifically talk about in Nebraska is North Platte, Nebraska, which is approximately 4 hours from Denver and 4 hours from Omaha, and is the largest hospital from South Dakota to Kansas. We cover also probably the largest hospital from an hour east to 2 hours west. So we cover a very large geographical area. When you're looking at a rural setting, a lot of times you're missing the key components. Dr. Savellas talked about, lack of those specialists or only having one specialist available. You're going to experience that in those rural settings. So one neurologist, one pulmonologist, and if you're in a critical access hospital, you're lucky to have those on an outpatient basis where the doctors would just go visit. In our area, we have one neurologist, one pulmonologist, and so we had to figure out how to keep our patients here, get them the timely care in our geographical location, so that way we can save the brain and also treat faster and transfer as needed. Go ahead and switch lines. So we're going to talk about those telehealth solutions. One of the big ones is, as we're talking today, implementing Telestroke network. When you're doing that in a rural hospital, whether it's a regional area, academic, whether it's utilizing in a critical access area, having a neurologist for 24/7 is important. It does improve those outcomes. So when you're looking at Great Plains Health in North Platte, Nebraska, they only had one neurologist when I became the stroke coordinator in 2015. And so they hired locums because Telestroke was just kind of more of a baby at that time. And so when that happens, we were spending hundreds of thousands of dollars to get a locum because we were a primary stroke center. And so we needed a neurologist 24/7. Well, the other issue that we ran into besides cost in a rural area is patients being seen. For a locum neurologist to come from home to the hospital after they were paged was approximately 18 to 22 minutes. And if you ever review the American Heart Association's time is brain quantified, every second you can lose up to 32,000 brain cells. So when you're looking at that, we had to change. And we wanted to save more brains. So we started doing Telestroke in 2016, and our times went down to 2 to 3 minutes for our patients to be seen, and it decreased our treatment times. Go ahead and advance the slide. So when you're looking at stroke and telehealth stroke awareness in rural Nebraska, and really any rural state, you're wanting to improve that access to care, giving them that professional development and utilization of telehealth stroke. So when you're looking down at the brass tacks of it, when you're looking at geographical size to improve access to care, what is that geographical size? Well, specifically in our region, it was the size of the state of Maryland, about 16,000 square miles. So we supported all of our critical access hospitals in that area for professional development. I would go out and teach about stroke. I would emphasize Telestroke because when I was able to travel, we'd already implemented Telestroke. But we were unable to provide those services to our critical access hospitals. So on top of doing that education, we would connect them with programs, systems that would be able to help them get this set up. We would also support them. But because I was doing that, when the Telestroke certification came out from American Heart, I realized I needed to get that certification so that way I can better support my area. Go ahead and advance slide. So when you're looking at American Heart Association Telehealth Stroke certification, that's what you're building on. You're building on your ability to help those areas, not just your area, but also surrounding and connecting with them. Go ahead and advance. So let's talk about that improvement. Advance. So the big things that you want to work at is your framework. What is best practice, which we heard a lot of those best practices with Dr. Savellas, and also that credibility. So when you're going out and teaching like I was, having that credibility, those best practices, and that framework and structure to help them was imperative. And when you get the certification, it helps teach you that structure because you're learning it as you're learning the program. So it made it easier for me to go out to those areas and teach them, help them get set up, and really be that outreach and connection for them. You can do that in a large aspect, but it's also really important because when you're looking at rural, that personal connectability is really important. And when they have a face, stories of improvement like we did, where it saved the cost to locums, and it also decreased the door to treatment time and being seen by a neurologist, those make the biggest impact for those patients in a rural setting. But a lot of times they want to just see a person that they know, a person they're comfortable with. And so having that credibility to have the certification support you behind that is really important. Thank you all very much. Do you have any questions?
So we do have some questions, and thank you for the amazing presentations, but Dr. Savilis and Cassidy, they were wonderful. So I'm going to start at the beginning. So there is a question here. We use StatRad for nighttime imaging results. Is there a best practice that facilities have used to ensure that Telestroke gets these results?
So it does vary based on how those results are given. Most often, those results are given to the ED doctor. And when we are preparing to treat, we kind of say that out loud to the room so everybody knows. And usually it is somebody's assigned job to let the ER doctor know. I mean, we don't wait for a radiologist official read if we are comfortable and confident. If there's a question about the image or something where we feel like we need their input, then we would rate and ask. There are instances where technology does fail us, where I will ask them to, is the doctor get a read? Did they get a read? Because for some reason I can't see it. But other than that, there isn't really a standard best practice to how to get that to them. But typically it's the ED doctor hearing it or the nurse, depending on the hospital's workflow. And when they get that, verbalizing it in the room to us while we're there for those patients that we know are going to get treated is the ideal way.
Great. You anticipated another question. They were asking if the Telestroke provider interpret the CT or if they wait on a formal radiology read before. So you read to treat while.
Yeah, the same way I would have when I practiced in person. I still look at the CT scan, every scan myself. Even with the radiology read, I will not treat unless I've looked at it myself, unless it's one of those one-off, can't get the technology, and that still gives me palpitations to not have seen it. But we typically do treat by just looking at them. If there's a questionable spot that we need to review with the radiologist, they absolutely need to be available. We value their input. Ideally, we have their read before we treat, but if it's delayed for any reason, we're not going to wait.
Okay.
Right. And I agree with Dr. Savilis. Our best practice also where you can work around, because when you have technology, it works until it doesn't. And we've had it where for some reason the neurologist was unable to connect in and look at the scan. And so we had them up on the telehealth system and we just scrolled through the radiology scans ourselves so they could see them that way. So there is the ability for them to see it, even if it's not their typical route.
I do caution against that though, because we have seen some small subarachnoids missed. So we won't, as a policy, treat just by viewing through the monitor. We can do that quick look through first, but small subarachnoids are really not seen through there. So I've seen cases. so there is, but you want to read in those two and you want to look at them on your own packs, ideally.
Okay. So is there a standard for checking the cart between uses, and do you do mock stroke codes to maintain competence? And someone else asked, is there a cart check log that is available that we can incorporate into their process?
So for what we typically recommend is shift, day shift, night shift. that whether it's the charge nurse or if they have a stroke champion nurse in the ED, there's different roles that take it on. But to each shift change, have somebody check the cart. So that's usually twice a day. In terms of logging it, I think everybody kind of does that their own way. However, their roles are to keep track of those type things. So I don't have a specific checklist. Mock strokes, yes, we endorse doing them often and we participate in them often. We'll even jump on screen, talk people through it, do fake patients and things like that to just try to make sure everybody has both the ability to keep it fresh, but also the chance to ask a neurologist questions in non-pressure situation about the workflow and if there's something they could be doing differently.
And just for those mocks, make sure you're doing it in the emergency department as well as on mocks on inpatient, because you still have those inpatient strokes. And if your inpatient staff doesn't know what they need to do, then it causes that delay in treatment.
Always a
Some cases, I think
challenge.
those inpatient ones are even more important because they thankfully get it less frequently. But
I was glad to hear you address the patient perspective. So have you evaluated, or has anyone evaluated patient and family satisfaction with the Telestroke programs?
so we do. We don't have it in I guess, the scientific way, but every single thrombolytic patient that we treat gets a phone call or attempts to call them from our quality team, and they get a patient satisfaction survey along with when we get our 90-day modified Rankins. So we do get feedback from patients in that way, and that feedback is given back to the physicians in terms of their experience and how things was, and if there's anything we can do to change or improve that experience. And that's kind of where some of those things come from, is things that we hear back from patients and how much it makes a difference when they feel like there's a comprehensive team taking care of them and they get the introduction and they know who that person on the screen is, not just some lady talking to them. that helps a lot.
It always amazes me that patients talk about the doctor on the screen like that doctor was in the room with them. So that
Try to make them feel that way as best we can.
That's a good job there. There's a question here. I'm going to read it as it's written. Rapid Eye, is it common for data metrics, i.e. times, assessment values, decision making, to be shared as a data set individualized per stroke alert or teleconsult? So I guess it's looking at that feedback loop between Telestroke and the providers at the hospital.
Yes, so that's pretty much how we do it. So it would trigger a case, and the case would have the whole Rapid Eye timeline for us, and we share that with the facilities and go through it with them to try to identify consistent issues they may have, or what we can learn from this case. How can we improve it? And that's really the format that it goes through with is individual case.
Okay, there's a question here about, do you use a video assessment even when the last known well is greater than 4.5 hours and patient is out of the thrombolytic window?
Yes, we do it for 24 hours. The thought is that they also need thrombectomy evaluation, and there's also the flip of that initial last known normal. I almost want to say 50% of the time isn't right. When we iron it down in a different way, sometimes it's symptom found, sometimes the question was asked differently, and we want it that way. You're triaging. You're not supposed to get all the details, but broadening that window to 24 hours takes away that risk of delay. If sometimes everybody thought they're out of the window and then we find out they're in it. So if you stick to 4.5 hours, you're going to miss treatable patients.
Okay, great. Cassidy, I think this is for you. Do you have any suggestions, directions for studying for the Telestroke certification? There is so much to know, and they're afraid they're going to miss something in preparing.
Yeah, when you're preparing, they do have a really great study guide to review. So just make sure you're going through that. Make sure you're doing it at your own pace. So like when you're studying, take some time, know that assessment as you're reviewing it. Some people's learning, they can go an hour and then they need a little bit of a break. And when you're reviewing, make sure you're reviewing those things about 3 to 5 times. It takes that many times for that memory to really implant in your brain. It is a 3-hour test, which seems daunting, but that's 175 questions. And so then when you're going through that, it makes it a little easier because you have the time to take. So while it says 3 hours, don't be afraid of that. That's actually helpful. But take your time studying before and use the study guide they provide.
Perfect. So do telespecialists need to be credentialed at the hospital that the patient is located at? And what about licensing if you see patients across state?
Yes, you need to be licensed and credentialed at every facility. Our licensing and credentialing as if we are in person, like every other person. They ask us for a flu shot and everything. So, there is no difference in how the credentialing shows up, which is why we have a wonderful team of 50 plus who credentials our physicians, because otherwise we would lose our minds.
Okay, I'm going to go one more question, and then I'm going to pass it off to Emily, who is going to give you some great insights on the exam process. So there's a question here. Does Telestroke obtain the 90-day modified Rankin score? Or does, from your perspective, Chastity, does the hospital provide the 90-day modified Rankin score to the Telestroke company?
So we do it on a case-by-case basis. Our telehealth system that we utilize here at Great Plains is different. And so we do random cases, and then they get feedback on those modified Rankins. But because it's case by case, they don't do it on all of them. We have probably 20 stroke codes in a month. And so we just pick a random amount to review with them and do that feedback on timeframes, on what patients might have said, things like that. So that way we get a good ratio of how it looks, but it is not on every patient.
So we do it on every patient. Every patient gets a phone call from one of our quality nurses. And I can't tell you we get a 90-day modified ranking on every patient because they don't all answer their phones, but they do try to call at least 3 times. And we do share with facilities. So they'll share the calls they get with us, and we'll share the answers we get with them. So it is a collaborative process through the program. And we have recently started doing it on some thrombectomy cases in addition to the thrombolytics at select facilities. So that need that extra support and help.
Great. Well, before I pass it on to Emily, I'd like to thank you all for participating, especially our speakers, and thank you all for the work you are doing in the community and with your community members. You're really saving lives. So, Emily, do you want to take it from here?
Yes, absolutely. Thank you so much, Jeannie. And thank you again, Dr. Sabelis and Chastity, for your time today. We did not really mention this, but both of them were and are part of our certified professional expert panel volunteer work to help support the development of our telehealth stroke professional certification and our upcoming stroke coordinator certification. We are excited to expand our professional certification portfolio under the stroke umbrella. And today we wanted to provide everybody who attended and registered for this webinar with a promotion to receive 40% off our telehealth stroke and our upcoming stroke coordinator certification, or you can purchase both for $500 with the code to take off $650. We just wanted to, again, offer this for you all for attending today and highlight the great work that is going on in the world of telehealth stroke, and also the role of the stroke coordinator in helping to deliver telehealth stroke programs and manage them, and also manage all of those stroke systems of care across your organizations and healthcare systems. And so I'm going to leave you all today with this slide, and we are here for more information, and we'll be following up with you all with our slide deck, more information about our promotion, and additional ways that you can reach out to us. Just want to thank everybody again for your time today, and I hope you guys have a great rest of your week. Thank you.